It's a pleasure really to have Dr. Antonarakis with us this evening. He's the Clark Endowed Professor of Medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota. Additionally, he is the head of Genitourinary Oncology there and the vice chair of translational research. Emmanuel's a long-term friend of mine, has been a great partner and a great mentor to me, and really helped me learn a lot of what I know about medical oncology. So Emmanuel, thanks for being here tonight. I can't wait to hear this talk, and I'm glad we have your slides up.
Thank you, everyone. And in Minnesota, most people go home at 4:30, so you guys are very motivated to be in your offices at 5:30 p.m. on a weekday. So congratulations. The office is empty here next to me. So these are my disclosures for this talk. And since this is a CME activity, these are the goals and objectives: to describe the type and prevalence of DNA repair alterations in prostate cancer, and then secondly, to spend the majority of the talk talking about the therapeutic implications of these, especially the homologous recombination deficiency mutations. So the landscape of prostate cancer, as many of you know, has become complex. It's a good problem to have, but on the other hand, we now have more and more drugs, including now lutetium PSMA 617, also called Pluvicto. Most of these are for molecularly unselected patients, but a few, including the PARP inhibitors and the MSI high indication, is for biomarker selected patients. So we're beginning to scratch the surface of biomarker selection in prostate cancer. So I'll review briefly for a clinical audience the DNA repair pathways, and then I'll talk about the therapeutic implications, focusing primarily on PARP inhibition, but also touching upon some other DNA damaging agents that may work better potentially in these patients. So there are 6 main ways that a cell, including a cancer cell, can fix its DNA damage. It can either do so one strand at a time, single strand repair. The most relevant mechanisms are the mismatch repair and the base excision repair. Incidentally, PARP1 is a base excision repair protein, which is relevant for this talk. And then there are mechanisms by which the cell can fix DNA damage 2 strands at a time, double strand repair. And the main one of these, and the one that has the highest fidelity and the least errors, is homologous recombination. And many of the famous genes, including the BRCA genes, are part of that pathway. So we now know from this study 7 years ago that these are present in about 20 to 25% of metastatic prostate cancers. They're also present in about 10 to 12% of localized prostate cancers as well. So they seem to be enriched in the metastatic patients compared to the localized. And we also know that about 12% of men have inherited germline DNA repair deficiencies, as first reported by this paper and subsequently confirmed by many, many other groups. One of the insights that we made early on after that germline paper was published is that while the prevalence is in fact 12 to 14%, there is enrichment in some of these unusual histological variants. So for example, in this study that we wrote about 3 or 4 years ago, we showed that if the histology contained ductal or intraductal carcinoma or variants, there was an enrichment in these DNA repair deficiencies such that 40% of those patients had one, whereas if the variant histologies were not present and there was just pure acinar adenocarcinoma, nothing else, the prevalence was a bit lower. So this taught us for the first time that if you have an unusual histological variant, it might be enriched for these DNA repair deficiencies. And if you take an extreme example, which is the pure ductal carcinoma, which are very rare, but at a place like Hopkins, we are a tertiary referral center for pathology, and we had collected actually 50 of these pure ductal cases. And we went back and showed that half of them, 49%, have a deficiency either in mismatch repair or homologous recombination repair. Again, making the point that in unusual histological variants, these genetic mutations may be enriched. So according to the current NCCN guidelines, and these are similar if you look at AUA or EAU or ESMO guidelines, germline genetic testing for prostate cancer patients is basically recommended quite universally for almost all patients with localized, locally advanced and metastatic disease, except for those perhaps with low risk localized or the very low risk localized. And then somatic testing is pretty much recommended for everyone that has metastatic disease or possibly even lymph node positive disease because of the advent of the PARP inhibitors and other molecularly targeted therapies. So why is this important? It's important because we have a new class of drugs, the PARP inhibitors, that work by this mechanism called synthetic lethality, where the drugs only have activity in cases where the homologous recombination function is crippled. And this was first suggested in 2015 by this initial study of Olaparib, showing that patients who had one or more of these mutations, BRCA2, ATM, BANK8, CHEK2, etc., were enriched for favorable responses to Olaparib, whereas patients that didn't have any of these mutations didn't have responses. And this translated into an improvement in radiographic progression-free survival if the homologous recombination deficiency was present versus absent, and overall survival. Now, when that initial paper came out, many institutions, including when I was at Johns Hopkins, we began to use these drugs off-label prior to the FDA approval. And what we showed in this study published by one of our fellows, who is now a faculty member, Dr. Marshall, is that these responses were very robust in the BRCA2 patients, less robust in the BRCA1 patients, and not so favorable at all in the ATM-mutated patients. And if you look at radiographic progression-free survival, the ATM-deficient patients, again, in this very small preliminary study, appeared to derive much less benefit than the BRCA2 patients. So hold that thought for now, and then I'll show you some other data that also supports that. So this leads us to Maha's study and Johan de Bono's study, Profound, which I'm sure she has presented many times. I'm just going to summarize some of the key findings. So this was the trial leading to the FDA approval of Olaparib in prostate cancer. There were two cohorts, a BRCA1, BRCA2 ATM-mutated cohort, and then a cohort B with 12 other mutations. And in each of the cohorts, patients were randomized to receive Olaparib versus physician's choice of enzalutamide or abiraterone. Now, in cohort A, which is the BRCA1 and 2 and ATM deficient, there was a very large PFS benefit with Olaparib, and with the final analysis, also an OS benefit, with two back-to-back papers published about 6 months apart from each other. And then, interestingly enough, because the first cohort A, was positive, the investigators and the sponsor then combined the data from cohorts A and B. This was a pre-specified statistical analysis, so they had the permission to do so. And when that was done, the radiographic free survival was significant in the overall patient population. Now, when you look at the gene-by-gene analysis, however, you can see some pretty interesting things. You can see that progression-free survival in the BRCA2 cohort was much superior in the Olaparib versus control arm. Same with overall survival. But when you start looking at some of the other genes like ATM, you don't see a big difference. Even BRCA1, for example, you're not seeing much of a difference across the control arm versus the Olaparib arm. And this begins to suggest, at least to me, that the benefit is being driven by BRCA2. Maybe not exclusively BRCA2, but at least it's being skewed a lot by the BRCA2 patients. However, since the endpoint in the combination cohort was met, and since this was a predefined statistical plan, the FDA did decide to approve Olaparib for a 14-gene panel. The 14 genes are listed here at the bottom. And this is for patients with metastatic CRPC who have progressed on one or more AR targeting agents, and they did not have to have received chemotherapy. So chemotherapy was permitted, but was not required. Now, there are other PARP inhibitors. Rucaparib is one of them, and these may differ in terms of their PARP1 enzymatic inhibition, and they also differ with respect to their PARP trapping. And Rucaparib has also gained an accelerated approval in prostate cancer, and this was based on the Triton-2 study, which I'll describe shortly, and then there's an ongoing Triton-3 study, which will lead to full approval if positive. But the Triton-2 study was a biomarker-selected single-arm trial where the primary endpoint was objective response rate and secondary endpoint was PSA response. Again, no control arm, non-randomized. And the objective response rate, as shown here on the waterfall plot, was quite impressive with about a 44% objective response in the BRCA1, BRCA2 patients, shown in brown. And then every once in a while, you can see the occasional BRIP1 patient or ATM patient that has a response, but the majority of the responses are driven by the BRCA2 patients. And the same thing was seen when you look at PSA response. So the sponsor of this study decided to file for an accelerated FDA approval, but only for the BRCA1 and BRCA2 subsets, and not to seek approval for the other genes in the panel. And that's exactly what happened. They received approval, but they received approval, unlike the case with Olaparib, for the BRCA1 and BRCA2 subsets. There was another difference, which was that this trial was a post-taxane population. So it's a third-line CRPC patient with exposure to an androgen receptor targeted therapy plus a taxane. Now, this is an accelerated approval. What that means is that the FDA reserves the right to potentially revoke the approval if the phase 3 study, randomized study, is not successful. And this is the design of the phase 3 Triton-3. And here they are focusing on the BRCA1, BRCA2, and ATM. So they've added the third gene in their phase 3 design. And the control arm in this case is a physician choice that includes Abianza or a taxane. And this is a pre-taxane population where a taxane is permitted for hormone-sensitive disease, but is not permitted for castration-resistant disease. So this is a second-line mCRPC population with docetaxel being incorporated into the control arm. 400-patient study, fully enrolled as of a month ago, and probably will be presented in the next 6 to 12 months. Now, one of the things that we wanted to study when I was still at Hopkins was the relative efficacy of Olaparib in patients that have BRCA1 versus BRCA2, because unlike ovarian cancer or breast cancer, where the efficacy appears to be the same, in prostate cancer, we had shown anecdotally that the BRCA1 patients don't respond as well. So we put together a consortium. Northwestern was part of this. And what we showed is, first of all, BRCA1 is much less frequent than BRCA2, about 90% less frequent, so 1/10 the frequency of BRCA2. But secondly, that both progression-free survival and overall survival in the context of a PARP inhibitor is inferior for BRCA1 patients compared to BRCA2 patients. And that's important because it kind of sets this cancer apart from other BRCA-associated cancers where the BRCA1 patients, as I mentioned, do respond just as well. It's unclear why this is the case. We have some hypotheses. The other interesting thing from that study was we showed that certain classes of mutations respond less well compared to other classes. For example, missense mutations in BRCA1 and BRCA2, where a single amino acid is changed but the protein is not truncated, don't respond as well as the protein truncating mutations, which cause the C-terminal domain of the protein to be deleted. The other interesting thing is if you have a concurrent PTEN mutation or a concurrent P53 mutation, those patients do worse. And interestingly, if you have a concurrent SPOP mutation, those patients do better, suggesting that SPOP also increases homologous recombination deficiency. These are all hypotheses that need to be confirmed in other settings. We also began to wonder whether more expansive definitions of homologous recombination deficiency beyond a single gene might be more predictive of PARP inhibitor benefit. And this is a study we did with Tamara Lotan, where we took about 20 patients with germline CHEK2 mutations, 20 patients with somatic or germline ATM mutations, and 20 patients with germline BRCA2 mutations, where we had radical prostatectomy specimens. We blinded the analysis of HRD function, and we sent these specimens to Myriad, and Myriad performed in a blinded fashion without knowing which was which. Their homologous recombination deficiency score, which is a score that goes from 0 to 100, with 100 being the highest homologous recombination deficiency and 0 being the lowest. And then after they had reported their HRD score back to us, we unblinded them to the germline data. And interestingly enough, and perhaps as you may have expected, the BRCA2 patients had the highest HRD scores. These are all prostate patients. The ATM patients had intermediate HRD scores. And interestingly enough, the CHEK2 patients had HRD scores that were analogous to wild-type patients. We then confirmed this in a second cohort where we showed that the BRCA2 deficient had the highest HRD and the wild-type patients had the lowest. Interestingly enough, P53 mutation itself, even in the absence of a HRR mutation, did slightly increase the homologous recombination deficiency score, but not as much as those with BRCA mutations. So we need better markers of homologous recombination deficiency and proficiency beyond just the gene-by-gene analysis. Now, you guys are going to be very privileged to see some unpublished data from a study that we have done that is undergoing interim analysis. So it's always exciting for me to present unpublished data. So we wondered whether these PARP inhibitors would be efficacious in patients with biochemical recurrence. In other words, people that have received primary local therapy with a prostatectomy, have subsequently developed a rising PSA, but no evidence of metastatic disease on imaging. And we thought we could study these patients, and we thought we could use the radical prostatectomy specimen to retrospectively examine the homologous recombination mutation status. But the goal in this study was to take 50 patients with BCR and to enroll all of them, irrespective of their HRR status, and then to do a post hoc analysis. So this was a three-staged study where the first stage was 20 patients, second stage was 10 more patients, 30 total, and the final stage was 50 patients. And what we've done is we've enrolled to the first stage and the second stage. We have, passed the futility analysis for these two stages. And we're now almost completed with the third stage. We've enrolled 47 of the 50 patients. And when Dr. Ross was at Hopkins, he had referred many patients to me for this trial. So thank you, Ashley. And what I'm going to present is the interim analysis after the 30th patient. Remember, we had the statistical permission to do so because it was built into the protocol. So these were the genomic criteria of the first 30 patients. Now, when you look down this list, what you'll see immediately is that there's an artificial enrichment for these mutations. There's no way that the natural prevalence of HRR mutations would be this many. And the reason why this ended up happening is if a physician or a patient happened to know that they had one of these mutations, they were coming specifically for this study, and many of these patients came from out of state. And as you can see here, there were 7 BRCA2 patients, 4 ATM patients, and then a bunch of other homologous recombination deficiency. Again, I want to make the point, this does not reflect the natural prevalence of HRR in BCR patients. It's way enriched. The first thing that we saw is that every single one of the responding patients, if you look at PSA 50 as your metric, either had a BRCA2 mutation or ATM mutation. In fact, 7 of the BRCA2 patients had a PSA response. Now, I want to point something out which may not be obvious. These patients were not receiving medical or surgical castration, so that we were not giving these guys any form of ADT or anti-androgen. So these PSA responses were purely a result of the PARP inhibition and not the result of any other systemic or local therapy. These patients were not getting radiation or systemic therapies other than the PARP inhibitor. So we had, as you can see, many profound responses here. We did see some minor PSA responses in the non-HRR patients, but none of them met the 50% threshold. If you look at it as a spider plot, again, the yellows are the BRCA2s, the blues are the ATMs, and the gray ones are neither. There were some patients that had very, very immediate PSA responses, while there were others, like this patient with the ATM mutation, where the response took about 12 months, but was quite sustained. So this is interesting. It supports the hypothesis that you don't need AR inhibition for these drugs to work. And in the appropriate setting, they may work in the absence of medical or surgical castration. So this was the first study, to my knowledge, that tested the PARP inhibition concept in the absence of concurrent hormone therapy. If you look at progression-free survival, none of the BRCA2 patients have progressed yet. The ATM patients have an intermediate PFS, and then the non-BRCA, non-ATM patients, on average, were developing progression, PSA progression, that is, within about 3 to 4 months. We then went one step further to design a study of Rucaparib, an alternative PARP inhibitor, in metastatic hormone-sensitive prostate cancer patients in the absence of hormone therapy. Now, everyone on this call might wonder whether this is ethical to even do this. And our hypothesis was, in patients that have germline or somatic homologous recombination deficiencies who sign a consent form and actively turn down hormonal therapy after being told that hormonal therapy plus or minus abiraterone plus or minus docetaxel is the standard of care, we thought that would be ethical. And we've managed to enroll several patients to this trial. It has not been as easy as we thought, because patients have to actively turn down a very, very effective standard of care. But we really wanted to ask the hypothesis again: can you give a PARP inhibitor in the absence of any other systemic therapy, even in metastatic patients? This was our very first patient. He was a germline BRCA carrier with a second somatic hit in his tumor, so a biallelic. And he's had a complete response to Rucaparib as a monotherapy, without ADT, without abiraterone, and without docetaxel. Is this ready for prime time? Absolutely not. Is this the standard of care? Absolutely not. But as a research tool, within the context of a clinical trial, by the way, we're learning a lot about this, because in this trial, we're getting pre and post biopsies, and we are showing, and I can present this in 6 months if you invite me back, we are showing that PARP inhibition has effects on the androgen receptor, which is pretty novel. And we are affecting the intracellular localization of the AR by using a PARP inhibitor, suggesting that PARP inhibition has effects on AR itself, which is a mind-boggling assertion if it's true. Now, I couldn't give this talk without acknowledging the recent studies showing synergy between PARP inhibition and androgen receptor inhibition. There are many rationales for this. One rationale is that the androgen receptor itself indirectly controls several of the DNA damage response genes and proteins by this intermediate step called DNA-dependent protein kinase. Conversely, PARP1 itself has been shown to promote the transcriptional function of androgen receptor. And thirdly, many of the resistance mechanisms for androgen receptor targeted therapy involve loss of RB1, and BRCA2 and RB1 are co-localized on the same chromosome, so you often get loss of BRCA2 when you lose RB1. There's been a number of phase 3 studies asking the question of a PARP inhibitor plus a androgen receptor inhibitor. And the one that we have seen the data of so far is this one, PROPEL. So in the PROPEL study, they looked at biomarker unselected patients. So they were not required to have a homologous recombination mutation. In fact, it was not known whether they did or didn't at the time of the enrollment. And this was a first-line metastatic castration-resistant trial where patients were randomized to receive abiraterone plus placebo or abiraterone plus Olaparib. And the study met its primary endpoint, showing that in an unselected overall patient population, the addition of Olaparib to abiraterone improved PFS compared to abiraterone alone. Yes, the difference was greater in patients with homologous recombination mutations, with the hazard ratio improving down to 0.5. But even in patients with known homologous recombination proficient status and absence of mutations, there still was a statistically significant benefit with the upper limit of the confidence interval not crossing 1. So it remains to be seen whether or not the combination of Olaparib plus abiraterone will be approved by the FDA in an unselected population. Part of me worries that we'll be shifting from a precision oncology approach back to an imprecision oncology approach by not doing this genetic testing. But many of us, including myself, would not be as enthused about using the combination in the HRR wild-type patients. At least I wouldn't be. Safety appeared to be manageable with some potential excess in nausea and maybe some anemia, but nothing that suggested synergistic, but probably just additive toxicities. Now, I want to spend about 5 minutes talking about other therapies that may potentially work better in the context of an HRR deficiency. And the first is a drug that we don't use very often in prostate cancer, which is platinum, primarily carboplatin. And this was a retrospective study where physicians chose to use carboplatin based on clinical parameters, oftentimes in combination with docetaxel, so docetaxel plus carboplatin. And then the authors retrospectively evaluated the homologous recombination mutations. And if you look at the Kaplan-Meier curve, I think it's depicted better on this part of the slide. If a homologous recombination mutation was present, the platinum therapy worked a little bit better compared to if the homologous recombination mutation was not present, suggesting that presence of HRR deficiency may sensitize to a platinum agent. Another interesting and provocative idea is that of radium-223, which is a alpha particle radiopharmaceutical compound that binds to bone and then emits a double-strand DNA damaging radiotherapy particle. And there was a study that was conducted at Hopkins and then another one done in Europe, suggesting, both of these were retrospective, that in the presence of an HRR mutation, radium has potentially greater efficacy. Again, hypothesis generating studies here. And I just want to share one of my patients with you. This was a gentleman that had a germline ATM mutation who had a very profound response to monotherapy with radium-223, with a 90% PSA reduction, a resolution of bone metastases on nuclear medicine, technetium bone scan, and a resolution of pain, which most of us would agree is not the typical thing that we see with radium. Again, suggesting that potentially this patient's ATM mutation may have made him more susceptible to the DNA damaging effects and hence the therapeutic effects of radium-223. I want to close with a caveat. This was a caveat that I was not aware of, and I think I made a therapeutic mistake with my patient, and I want to share it with you. So this is a de-identified Foundation Medicine report. There's no identifiable information here. This is a patient with a pathogenic frame shift loss of function BRCA1 mutation, but also a concurrent mismatch repair deficiency in the same patient. High MSI and high TMB, 20 mutations per megabase. When I first met this patient, I was excited to treat him with Olaparib. This was back in the early days. And I gave him Olaparib, and his disease continued to progress. In fact, it may have accelerated a little bit. And after 3 or 4 months, I abandoned the treatment. And then almost as an afterthought, because of his mismatch repair deficiency and the recent approval of pembrolizumab, I decided to treat him with Pembro. And he had a very profound and immediate response that lasted about 12 months prior to a subsequent progression. So I began to wonder how common this was, where you have a patient that has both MSI high and BRCA mutation in the same patient. So I collaborated with Foundation Medicine. This paper is unpublished, but it's in press right now, and I got permission from them to share these data. So this is the entire Foundation Medicine solid tumor database, consisting of almost 50,000 patients. And you can see there is an overlap between those that have HRR mutations and MSI high mutations. If you focus on the MSI high subset, 148 of the 32,000, which is about 5%, have a concurrent BRCA1, BRCA2 mutation. So it's not that rare. What we then showed is, if you look at the TMB in bins of 10 units of TMB, what you can see is as the TMB goes up, the prevalence of BRCA mutation goes up. But these BRCA mutations are the monoallelic ones that increase, not the biallelic ones. So the prevalence of biallelic BRCA is not influenced by TMB. It stays at around 4%. But what goes up with TMB is these monoallelic mutations, suggesting that they are a consequence of, in other words, a passenger of the TMB status, not a true primary driver event. What we then showed is that this phenomenon of a secondary passenger BRCA mutation as a consequence of mismatch repair deficiency happens more often in prostate cancer than any of the other BRCA-associated cancers. So there's something weird or unique about prostate cancer that makes this phenomenon more common. And secondly, the phenomenon is more common with BRCA1 than with BRCA2. So 15% of MSI high prostate cancers have a concurrent pathogenic BRCA1 mutation. So that's a high prevalence. And by the way, my patient was one of them. And then about 4% of MSI high have a concurrent BRCA2. So altogether, about 20 to 25% of the MSI high prostates also have a secondary passenger BRCA1/2 mutation. These are almost always monoallelic, not biallelic, and they wouldn't be expected to respond to PARP inhibition. And this is also exemplified when you look at the GLOH scores, suggesting that when a BRCA mutation occurs in the context of an MSI high, it does not lead to homologous recombination deficiency. So in conclusion, somatic and germline DNA repair mutations are prevalent in prostate cancer. They are enriched in metastatic disease compared to primary disease, and they might be enriched further in histological variants such as ductal carcinoma, intraductal carcinoma. They do sensitize, as we all know, to PARP inhibition, but there are perhaps some other therapeutic opportunities for these patients, such as the use of platinum agents and maybe even DNA damaging radiopharmaceutical drugs. I didn't talk about lutetium PSMA, but these findings may extend also to lutetium. I believe that not all homologous recombination mutations are equally efficacious in the context of PARP inhibition. I've shown you a caveat whereby a homologous recombination mutation might be a passenger event associated with MMR, but would not be expected to lead to PARP inhibitor sensitivity and rather would lead to pembrolizumab sensitivity. And finally, we are all in need of better functional assays of homologous recombination deficiency so we can go beyond the gene by gene analysis. Now, a lot of this work was done at my prior institution. These are my mentors, friends, and colleagues who did much of the work, including our two fabulous GU pathologists, Dr. DeMarzo and Lotan, who did many of the correlative analyses that I presented. And this is my new home, the Masonic Cancer Center in Minneapolis. And with that, I'd like to thank you for your attention. And I will stop sharing so that we can have a robust discussion. And thanks very much.
I think, I share, Emmanuel, I share your concern about the PROPEL data. And I think that the design was not as clean as it should have been. I think the magnitude was better designed in terms of clean upfront stratification. And so it'd be interesting to see what the FDA will do. But even when you look at the subtleties of the data, not everybody got results. Some got tissue, some got ctDNA. There's a lot of things that could have contributed to the differences. So it'd be interesting to see for sure. The other thing I would say, I do like, again, the data that you're showing in terms of the hormone-sensitive space patients. My main concern, actually, even as we move the drug into the hormone-sensitive in combination with whatever, as you know, trials are being done with PARP inhibitors. The issue, I think, the long-term toxicity and the effect on the bone marrow. And I wonder if you have some comments about that.
Yeah, in the other malignancies, there is a 1% risk of myelodysplasia and acute myeloid leukemia, which is concerning. We worry about these things. And we worry about these things in people who have a bone marrow full of prostate cancer that can perhaps accelerate some sort of myelodysplasia as well. But so far, as you know, Maha, in the prostate cancer studies, we have had now a number of phase 3 studies. We have not seen any MDS or AML yet.
Oh, no, you're right. But these are, remember, this is, again, patients who are end-stage disease, right, living forever. The issue comes up is sort of like an adjuvant in the context of breast or ovarian, for example, in the setting of prostate, how long we would treat and the effect there. So, I mean, I think there are some subtleties there that I think is important to consider.
I agree, but, there was someone that ran a mitoxantrone study many years ago, and as you remember, Maha,
yes,
that was closed because of MDS, and those patients were advanced as well. So I think it's something we need to pay attention to.
Yes.
The other thing is, the chronic use of these drugs, nausea is a significant problem, anorexia is a significant problem, and weight loss. A lot of these patients lose weight because they're not eating as much.
Yeah.
And, with 3-year, 4-year use, these problems will add up. And one of my concerns about the abiraterone plus Olaparib combination is patients are taking 10 pills per day. They're taking 4 abiraterone, 2 prednisone, and 4 Olaparib. That's a lot of pills. And they're on that for 18 to 24 months. That's a long time. So in order to adopt this, I need to be convinced that my patient is going to benefit.
I agree. And one final maybe thing is, do you actually think all PARP inhibitors equal?
No. I don't. And I think Tia Higano was very, very careful in her discussion at the ASCO GU to make that point, and I agree with her. Having said that, they're not all the same in terms of toxicity. I think we can all agree on this. They may not all be the same in terms of efficacy as well. And one of the things I want to point out, and this is a subtlety as well, but in the Magnitude trial, they were forced to reduce the dose of niraparib by about 1/3. So the dose went from 300 to 200 milligrams. Whereas in the Olaparib study, the Propel, the dose was maintained at the 100% dose that was used in the monotherapy, which is 300 BID. And some people have said that the Magnitude study, even in the BRCA2 subset, for example, the impact was not as great. And I would agree with that. And one of the reasons might be because with certain combinations, we may not be able to give the full dose of PARP.
Correct.
And this may affect the efficacy in the end.
Great. Agree.
Emmanuel, this is Bill Catalone. Great talk. So in your patients with biochemical recurrence, are they receiving the 100% dose, the full dose?
Yes, they are, Bill. And about 10% have had to have a 1-level dose reduction. And the 3 or 4 patients that have had to reduce their dose, we have done so because of anemia. Anemia is a class effect. We had one patient that required a transfusion, and he's like, I'm not going to do this. So we reduced from 300 to 250. And then there were 2 other patients that had, grade 2 anemia, which, on paper doesn't sound bad, but grade 2 anemia is like a 3-point hemoglobin drop. And they were fatigued. And remember, these are patients that have lifespan of 10 to 15 years. They're not willing to tolerate grade 2 anemia. So we're learning a lot. The adverse effect tolerance is much, much less in these patients. And they're on it for much, much longer.
So, to shift the context a little bit, in women who are pathogenic BRCA mutation carriers, who would like to complete their families, before having prophylactic surgery, what would your thoughts be about whether they could tolerate something like a mini course, say for 6 weeks a year or a month a year of PARP inhibition? Is that something that would be like totally crazy in a woman who was in her 20s and 30s? Or do you think that that would be something that people would be interested in studying?
I don't know if a 1 month per year or 1 month on, 1 month off would have a prophylactic effect. This is not an immunotherapy. It doesn't lead to any, long-lasting changes. You can think of it as a chemotherapy that works in a particular genetic context. I worry about doing that to a 20, 30-year-old lady. Having said that, we just recently heard about the FDA approval of adjuvant Olaparib in curative resected breast cancer patients with germline BRCA1 and 2 mutations, the so-called Olympiad study.
Right.
Like 3,000 patients randomized, amazing effort. So one thing that I've often wondered, to bring the conversation back to prostate is, could we ever, and this is a question for you as a urologist and Ashley and the other urologists, could we ever convince our urologists, because they're the gatekeepers of germline testing for the localized patients, could we ever do that study in prostate?
In patients who were BRCA2 carriers?
Germline carriers, yeah.
Yeah, and you do adjuvant. The trouble, Emmanuel, is unlike the younger women with breast cancer, which is much more aggressive, prostate, these men can go for 20 years. So how do you get the read? That's going to be the issue.
Yeah, I think the read would have to be biochemical recurrence, which is imperfect. I'm not sure whether these patients live 20 years, whether or not they should exit from the active surveillance program is one controversy. I know that Val Carter thinks that they should. Most other people don't agree with that, based on his European urology paper. But you are right that it doesn't always equate with necessarily bad disease.
Well, Emmanuel, for the folks that you had on your trial that discontinued, I know there's only very few that dose reduced or maybe discontinued. In the BCR setting, did anyone have a long-term response after discontinuation even?
No, within about 3 months, their PSA began to increase again.
Oh.
Yeah. That was disappointing. For example, we had 2 patients with complete responses. PSA went to 0. And in fact, one of the 2 was in his 80s, and he looked at me and said, what if you give me an MDS? I don't want to have an MDS because of this, and I'm in a complete response. So the trial was written in such a way that if they interrupted the drug for more than a month, they couldn't go back on it. And perhaps in retrospect, I should not have written it that way, but I did. And so he came off of it for 3 months, and by the 3rd month, his PSA was rising. And we decided not to modify the protocol, so he just stayed off.
So, Emmanuel, this is Bill Catalone again. So have you or has anybody else looked at, prostate cancer risk SNPs as being able to, predict response to therapy?
We have not. As you know, there's an interest in these so-called polygenic risk scores, where you take a SNP that individually, has a very, very low prevalence of prostate cancer, and you add it with other, low penetrance SNPs, and all of a sudden you have this 90% lifetime risk of getting prostate cancer. I think many of those SNPs are not in HRR genes, actually. For example, some of them are in HOXB13, which has absolutely nothing to do with homologous recombination deficiency or other genes, even with unknown functions. So I have not heard of that study being done. And I don't even know if it would make biological sense unless the SNPs are somehow restricted to like DNA damage SNPs.
How many DNA damage genes are there?
Well, in the PROfound study, they claimed that there were 14. There are probably, if you look at all the 6 DNA damage pathways, there's probably 100. If you look at homologous recombination deficiency, there's probably 20.
Mm-hmm. But Bill, they're not equal, and the frequency is totally, basically BRCA2 is the biggest one, and then ATM is there, but also not as much. CDK12, I think, is another one. So the reality of it is they're not all equal, and they're not there. And one thing I was always curious about, Emmanuel, have you ever had cases where they have more than just one, like BRCA and ATM? Did they behave differently?
Anecdotes.
Okay.
You have that data from PROfound, but it's so few. It's so few.
Yeah. And with the PROfound, we started with a 15-gene panel, and one of the genes was removed because it was not thought to be after the fact that it was actually, an HRR kind of pathway.
So Maha, Pete Nelson has a very interesting study that he published in JCI, Journal of Clinical Investigation.
Yeah.
Where they looked at the West Coast Stand Up to Cancer CRPC biopsies, and they developed this HRD score, which it was one of the cosmic signatures. I think it was signature 8. I can't remember for sure. And they tried to answer that question. They tried to answer the question: is that signature increased in people that have 2 versus 1?
Sure.
And there was a numerical increase, but once you start looking for these compound mutations, the sample sizes become so small.
Yeah. And that's actually what we found. In fact, the table you showed specifically from the PROfound, these were the most frequent, but by default, really, there is like the usual suspects, and these are the top 3, and that's what's more common. You know, in the field, I'll tell you, after 100 years in the prostate cancer field, what is fascinating is the AR will continue to be the backbone of everything. So as much as we want to prevent people from getting, you know, AR inhibitors, nobody wants to be castrated, blah, blah, blah. At the end of the day, the AR is a huge, huge backbone of everything we do. And actually the disease behavior.
So in that regard, Emmanuel, so do you feel that the patients who respond to PARP inhibitors, you know, who don't have known, you know, DNA repair deficiencies, do you feel that that is through an AR mechanism?
I don't happen to believe that. I believe that they have either undiagnosed or unmeasured homologous recombination deficiency. You know, you have to remember, if a patient has, let's say, a hemizygous deletion, so a deletion of one copy of BRCA2 or BRCA1, that will never show up in a clinical report. It will only show up if it's a homozygous deletion or if it's pathogenic. And then there's the other issue that Maha mentioned. What if you have 3 or 4 heterozygous mutations, neither of which is pathogenic on its own, but working in concert with each other, they do induce homologous recombination deficiency. And what if that list of 20 genes, you know, is 50 genes, but the other 30 are not discovered yet? So that's why I think that I'm intrigued by these HRD scores. They are also imperfect and they have not been clinically validated. So we can't just say that because the HRD score is high, that's going to equate to a PARP inhibitor sensitivity, but I would love to see those studies being done.
So how are the HRD scores tested again? What is the science behind that?
It depends on the proprietary algorithm. So, for example, Myriad, which has the most comprehensive one, they look at 3 factors and then they sum them all up. They look at loss of heterozygosity, how much of the genome is under loss of heterozygosity. Number 2, they look at this thing called telomeric allelic imbalance. How many of the telomeres are imbalanced? In other words, one telomere is gone, but the other is present. And thirdly are these so-called large state transitions, which basically means they count the number of large translocations. And then they add those 3 things up, and then they normalize it to a score that goes from 0 to 100. There are other companies like Foundation Medicine that only report the genome-wide LOH. They call it GLOH. And that basically says how many of the chromosomal segments have loss of that wild-type copy. None of these are perfect. They're all different. They're proprietary, so you don't know exactly how they're measuring it. It's a challenge.
Hey, Emmanuel, it's David Vanderweel. Great talk. Always helpful to get your insights. You know, you showed mixed data for ATM. Clearly, it's not the biomarker that BRCA2 is, although you do see some responses in some settings. So I'm just curious how you think about the treatment landscape in folks with the ATM mutation.
Yeah, you're absolutely right that some ATM deficient patients respond. You know, ATM is an interesting gene because you don't always or often see a biallelic hit of ATM, as you almost always do with BRCA2. And there's this concept in the field of haploinsufficiency. In other words, that one mutation is enough to disrupt the function of the gene. I'm not sure if we have proven that in humans. The way that I would answer that is, I think for now, PARP inhibition may be the best thing that we have. However, there are probably other targeted approaches for that specific subset which might be more fruitful. And one of them are these so-called ATR inhibitors. So ATM and ATR are both involved in sensing of DNA damage. They're not really effectors of DNA repair, but they're sensors of DNA damage. And it seems to be the case that when one is mutated, if you knock out the other, you can get a synthetic lethality. So in the context, as you well know, so in the context of an ATM mutation, perhaps inhibiting ATR rather than PARP might be more fruitful. And there's many ongoing studies, including in prostate cancer, with the AstraZeneca ATR inhibitor and the Bayer ATR inhibitor.
So, Emmanuel, I know we're over time. This is Bill Catalona again, but could you say a few words about overcoming resistance, about where that field stands?
Yeah, we've learned a lot about resistance from ovarian and breast cancer. One of the mechanisms of resistance are these so-called reversion mutations, where the mutated BRCA gene reverts back to wild type. It's actually a misnomer because the gene doesn't revert back to wild type. What happens is it develops a second mutation that restores the open reading frame. So you no longer have a frame shift and a truncation. And that partially or completely restores the function of the BRCA2 protein such that the synthetic lethality is no longer present. Now, in prostate cancer, this has been detected and confirmed, but it only accounts for about 20% of the secondary resistance, and it probably doesn't account for any of the primary resistance. So there's still a lot to be learned. One of the things that I've noticed is that my patients who have a BRCA mutation and a concurrent p53 mutation, those patients respond less well and less long to PARP inhibitors. So the other known negative prognostic factors like p53 mutation, p10 mutation, RB1 mutation, when those coexist with BRCA, those patients, in my opinion, also don't respond as well. But there are obviously other things that we're not aware of. The other issue is, tumor heterogeneity. When you do a liquid biopsy and you find a BRCA mutation in a circulating tumor DNA, you don't know if every metastasis in that patient has that BRCA mutation, or if that metastasis that's in the bone has it, but the one that's in the liver doesn't have it, or vice versa. So there might be clones or subclones that don't even have the BRCA mutation in the first place, in which case, that subpopulation would not respond.
Emmanuel, again, we can't thank you enough for sharing your knowledge with us and for going over this and having a great discussion afterwards too. Really good to see you. Hopefully we see each other at ASCO and beyond. And thanks everyone. Thanks for the great points, Maha, Dr. Catalona, the rest of the group. Really nice discussion.
Thanks very much.